So the lacerated wound has the zigzag pattern. Major issues damage may occur. Major tissue damage may occur and may grossly contaminated. Assessment of the patient with a lacerated wound. So it is a feature. So at first, if we think about a lacerated wound margin, then it should be a zigzag pattern wound margin, and there should be major tissue damage. So there is one important factor is tissue damage, and it should be major. And may be grossly contaminated. So another important factor is contamination. Assessment of the patient with the lacerated wound. So what we have to do for the assessment, we have to evaluation the patient. Evaluation the patient by history taking, complete physical examination. Now blood sent for the grouping, cross matching, blood sent for grouping, cross matching, hematocrit value, electrolyte and urea values, RBS, etc. Blood is sent for grouping, cross matching, hematocrit value, electrolyte, urea value, and RBS. Now radiological examination. At first we send the blood as we usually do, then we start for the radiological examination. And for radiological examination we should perform number 1 chest x-ray, number 2 x-ray abdomen in the erect posture, and number 3 other x-rays if needed. Now for the recording of the vital sign, we know as the vital signs is pulse, BP, temperature, respiratory rate. Now principles of management of lacerated wound. At first we have to exploration of the wound, the excision of the devitalized tissue, what we called debridement, and toileting under general anesthesia meticulously. So this is very important point that we have to go through toileting under general anesthesia and meticulous toileting. Keep the wound open initially if gross sepsis is present. Delayed primary suture or secondary suture is given. If patient comes within 6 hours, then primary suture can be given after making it clean cut incised wound. So this is very important, the duration. If I want to say about the duration, that if that wound come within the 6 hours, so this is the golden time. If patient come within the 6 hours, then we can give suture within 6 hours. But if patient come after that, then we can give delayed primary closure or secondary closure. And there are some several plastic surgery okay, the answer is finished here. Now come to the another question, which is another MCPS topic, and another just make a save, okay, so that we can yes. So what are the suture material we used in the surgical practice? Accurate tissue approximation is essential for repair of the defect, and this is achieved by the use of suture, staples, clips, and tissue glue. A suture is a strand of material used to repair defect. Approximation, anastomosis, vessel ligation, and bile sewing. So what we usually perform? We usually perform approximation of tissue. Approximation of the tissue by the suture material. What we perform? We perform anastomosis of the different thing. to the different thing. And what we perform, we same kind of vessel ligation, we same by sewing it. The criteria of an ideal suture material. Suture material should be non-filament, monofilament, strong, flexible with adequate strength, minimal tissue reaction, predictable absorption, holds not well, easy handling, non-allergic, non-carcinogenic. So these 7 criteria, if present in one thread, then it is called the suture. Monofilament, strong, flexible, minimal tissue reaction, predictable absorption, and holds the knot well, holds the knots well, and easily handling. So it is very easy to handle. And non-allergic, it does not irritate the muscle, and non-carcinogenic. The classification of the suture material is very important. According to the duration of the absorption, there is absorbable, natural, catgut, synthetic. What we use, Vicrin, polyglycolic acid per Dexon, and PDS. Even proline. Okay, non-absorbable. There are natural silk and synthetic proline and nylon. On the basis of the handling and knotting requirement, there is monofilament and polyfilament. Among the monofilament, the PDS and proline is very important, and among the monofilament, Vicryl and Dexon. According to the source, there is natural. Natural is catgut, and synthetic is Vicryl, Dexon, PDS, proline, nylon, etc. Selection of the suture material. Absorbable suture material for tissue which heal quickly, bowel anastomosis. Non-absorbable suture material, tissue which heal more slowly, abdominal wall closure. So in case of abdominal wall closure, we use proline. Here they want to say about that. And the smooth and sutures for running stitches, as the like vascular surgery, they need smooth running suture as they slide easily through the tissue. Braided suture for the knotting properties. If the suture is braided, then we need their knotting properties like ligating particles. Biological suture structures. We need silk and catgut causes inflammatory reaction and undergo enzymatic absorption. Thus, persistence in the tissue and strength are unpredictable. Absorbable suture material. Absorbable suture material. One natural and synthetic. In the natural, there is catgut, plain catgut, and when it is uh, submerged in the chromic, then it is chromic catgut. And synthetic is all P. It is a very interesting local is P. Even proline, absorbable here. This is absorbable, but not proline. Polyglycine, polyglycolic acid, PDS, and polyglyconate. Polyglycine, polyglycolic acid, PDS, and polyglyconate. Plain catgut derived from the collagen of healthy cattle and sheep. Submucous of the intestine of the cattle and sheep. It is actually not from the cat gut, it is from the cattle gut. The absorption rate, loss of tensile strength rapidly, 7 to 10 days by the phagocytosis and enzymatic absorption. Tissue reaction, there is high tissue reaction. The clinical use, we used to ligate superficial vessels, suture subcutaneous tissue, and stoma and other tissue that heals rapidly. Chromic catgut derived from the same source as plain catgut but tanned with a chromium salt to improve the handling and resist phagocytosis and degradation in tissue. Loss of tensile strength from the 7th to 10th days, it comes to the 21 to 28 days. Absorption, phagocytosis, and enzymatic degradation within 90 days. The tissue reaction, moderate tissue reaction, clinical use same as plain catgut. The synthetic there is polyglactin. Polyglactin is actually vicryl. So another name of this violet switcher is called vicryl, violet vicryl polyglactin, and types of the braided multifilament. Raw material copolymer lactide and glycolide in ratio of 90 is to 10. So here lactide and glycolide, lactide is more, is 90% and the glycolide is 20. That's why this is called the polyglactin, which is coated with the polyglactin and calcium stearate. Okay, actually misunderstand it, then it is actually lactide and glycolide and coated with polyglactin and calcium stearate. Absorption rate, come complete absorption within 60 to 90 days. So it is important information that absorption is within 60 to 90 days. Tissue reaction is mild. Clinical use has become the workhorse for many applications in the most general surgical practice, where epidural suture is required, cut anastomosis, vascular ligature, subcuticular wound closure, and ophthalmic surgery. So this four part, when we need to anastomose the cut, to cut anastomosis, and we need vascular ligature, and we need subcuticular wound closure, and ophthalmic surgery. The polyglycolic, Dexone, the braided multifilament, dyed or undyed, coated or uncoated raw material, polymer of the polyglycolic acid coated with the inner surfactant, inert surfactant, polyoxamar. So this is a polyoxamar. When Dexone, polyoxamar, DEXON, polyoxamar. This oxamar, actually polyoxamar, which denotes the Dexone. Okay, this is actually polyglycolic acid, polyglycolic acid, polyglycolic acid, Dexone, polyglycolic acid coated with polyoxamar. So what is Dexone? Dexone is the polyglycolic acid coated with polyoxamar. Clinical use where the epidural suture is required and particularly where there needs slightly longer support, gastrointestinal, urological and gynecological operation. PDS, polydioxazone sulfate. Polydioxazone sulfate type is monofilament, dyed or undyed. Raw material, polyester. Complete absorption 180 days. Whether there is uh, the PDS, sorry, when the catgut is only 7 to 10 days. When it is chromic catgut, it comes to from the 7 to 10 days, it is 21 to 28 days, so near 1 month. And same manner is the PDS, monofilament dyed or undyed raw material, polyester polymer, complete absorption 180 days, tissue reaction is mild. Clinical use is same as previous but a particular longer on support required. Polyglyconate Maxone, actually it is not familiar to us, that is Maxone. The polyglycolate absorption, complete absorption in 90 days, Maxone. Non-absorbable suture materials, there is also Natural and synthetic. There is also natural. Among the natural, there is silk, types braided and multifilament, dyed or undyed, coated or uncoated origin, biological origin from the silkworm. The tensile strength is 80 to 100% of the tensile strength is lost within 6 months. Tissue reaction, it is actually a highly reactive tissue, so there is a high tissue reaction, and this is a haven for the bacteria. This is a very important part. The clinical use usually used for skin closure. Now comes with the synthetic. Polypropylene, proline and polypropylene both are same thing. So we have to keep this polypropylene in our mind. Type is monofilament, raw material is polymer or polypropylene, polymer of the propylene. The tensile strength infinite, more than 1 year. So when the tensile strength is more than 1 year, we can consider it infinite, non-absorbable, and remain encapsulated in the body. Tissue reaction low. Clinical use cardiovascular surgery, plastic surgery, orthopedic surgery, ophthalmic surgery, general surgery. So in my home there is ophthalmic surgery. I am a general surgeon, and there should be the cardiovascular, plastic, and orthopedic surgery. So the nylon, polyamide polymer. So what is nylon? Nylon is polyamide polymer. Types monofilament or braided, multifilament. Tissue reaction low. Uses skin closure, abdominal wall closure, hernia repair. Now comes polyester. Now comes linen. Clips. Now short note about clips. Clips are often or instead used instead of sutures. Types of side application, ideal for skin closure. So in the skin, it goes like this manner. Here actually side application ideal. The in clip application ideal for attachment of the in clip application prosthetic mesh during hernia repair. So there is actually tacker in clip application. Example is titanium clip, plastic clip, actually hemo clip, liga clip, granny clip. So there is PDA ligation, which is known as a liga clip, and granny clip in neurosurgery to prevent bleeding from the scalp margin. Okay, so there is a plastic, this kind of I'm sorry, it is a radically is necessary to prevent bleeding from the scalp margin. Average is PD application. Advantage is PD application. Minimal disturbance of the blood supply to the edges. Easy removal. Applied safely in the HIV or hepatitis B virus positive patient with a risk of needle prick. Disadvantage: the risk of nerve entrapment by the clip, especially during laparoscopic hernia repair, costly foreign body granuloma acts as artifact in the subsequent MRI. Conclusion: clips are now widely used in skin graft and attached prosthetic mesh in the hernia repair. So this is the tourniquet, another MCPS production. The short note use of tourniquet in the surgery. It is the surgical tool which is used to exert circumferential pressure to occlude the blood vessel to achieve bloodless operation field. So this definition I like it most. It is a tool which applies circumferential pressure to make area bloodless or occlude blood vessel and to achieve bloodless operation field. Principle of application: position of the tourniquet must be appropriate. It should be in the upper arm, proximal thigh, finger must be checked by the operating surgeon. So it is the responsibility of the surgeon to check whether it is placed in the right place, in the upper arm or in the thigh or in the finger. With the tourniquet must be adequate. So width of the tourniquet is very important and it should be adequate. Elevation of the limb and exsanguination of the blood prior to application of the tourniquet is essential. Good padding is essential to prevent nerve and muscle injury. Time of application and time of release must be recorded by the anesthetist, surgeon, and record time. Over and prolonged inflation should be avoided. Tourniquet pressure: general tourniquet pressure is 50 mm mercury above systolic blood pressure, so that if one systolic blood pressure is 120, then we can give 170 pressure. The maximum upper limb, maximum upper limb 50 to 100 mm mercury above systolic blood pressure. So in case of upper limb, then we have to go for 220. Well, we can go up to 220 actually. General tourniquet time is 60 to 90 minutes or 1.5 hours. Max upper limb 90 minutes. General disease and maximum in the upper limb 90 minutes and lower limb 2 hours. So in case of upper limb we consider 1.5 hours, and in case of lower limb it is 2 hours. Commonly used of the tourniquet: smart bandage, pneumatic tourniquet, arm band, sphygmomanometer, for finger, fine rubber catheter, gloves, etc. Indication: anesthesia, facilitate the regional anesthesia, bears of oncology, the isolated limb perfusion, treatment of the advanced stage of the malignant. Surgery: prevent blood flow to a limb in order to achieve bloodless surgical material, facilitate venipuncture and access. Contraindication: there is some sort of contraindication, and there should be some absolute contraindication and some relative contraindication. In case of absolute contraindication, peripheral vascular disease such as Barrett's disease, presence of the local malignancy, presence of sepsis, comminuted fracture, and immobilized limb by plaster more than 48 hours, because chance of embolization from the venous thrombi. And relativity: if there is infants and patient with heart disease. Complication: commonest complication, nerve injury causing tourniquet palsy, ischemia leading to gangrene, tourniquet edema, joint injury, chemical burn or blistering from skin and preparation leaking under tourniquet. Tourniquet failure: due to inadequate application of the tourniquet and is rarely caused by failure of the cuff machine. It may lead to some arterial inflow, but with blocked venous outflow, which venous engorgement. Surgical field is caused. Cuff removal at once and reapplication is needed if necessary. So there may be some complication. Number one, there may be skin trauma, there may be volume overload, there may be metabolic or blood gas changes, tourniquet pain, tourniquet failure, post-tourniquet syndrome, hematoma, bleeding, muscle injury, nerve injury, compartment syndrome. Inadequate padding causing bruising, abrasion, and blistering. Burn may occur when preparatory solution sip under the cup, falling over limb exaggeration, and autotransfuses blood into the central circulation may not tolerate a poor cardiac result. Metabolic blood gas under the decreased pH, decreased partial pressure of oxygen, increased partial pressure of there is decreased pH, decreased partial pressure of oxygen, increased partial pressure of carbon dioxide, increased potassium, and increased lactate. Tourniquet may occur despite adequate anesthesia. Tourniquet failure, inadequate pressure, inadequate exsanguination, faulty equipment. Post-tourniquet syndrome. Swollen, stiff, pale limb with weakness but no paralysis, severe weak duration. Postoperative edema is the main etiology. Hematoma and bleeding. Bleeding causes not identified intraoperatively, delayed blood flow after tourniquet. Muscle injury, ischemia-related, nerve compression, radial most commonly, and common syndrome rare. So, the conclusion is vital surgical tool that may help the surgeon to creating bloodless field and thus ease the medical surgery will be ensured. Okay, now come to the another important measure. What safety measure you will take before using an electrocautery or diathermic precaution for the safe use, general safety. Ensure whenever electrical equipment is to be used on patient meet the required safety standard is properly maintained. So for this we can go to the nexus because here the basic surgical skill 127. So here we have to see that there is a same question regarding diathermy. The safe use of a diathermy energy source. Okay, ensure safe use of electric cautery during surgery. So this question number 9 is the same question in the MCPS volume 1. What is the safe use of diathermy? So these both are as 139 same, so we can learn from here. So prevention of the complication of the diathermy use, there is some broad headline. At first regarding the patient plate and site, second regarding patient, third in laparoscopic procedure, fourth regarding diathermy, 5 patient with pacemaker. So these 5 are the broad headline. Now come to the point. Plate and site should be shaped. Contact area should be at least 70 centimeter square. Should be as close as possible to the opposite side. It should be as close as possible to the opposite side. And should we have good blood supply? Blood supply is very important. Avoid bony prominence and scar tissue not kinked or creaked. Skin preparation fluid should not allow to sit under the plate. Must be inspected at the end of procedure. So you have to think that if there is a limb, what should we do? The limb should be free of hair, so it should be cut or clean. Then it should have a very good blood supply. So it is important that it should have good blood supply, and we should avoid where there is bony prominence. So we should avoid all sort of bony prominence. Okay, there is bony prominence. Then not kinks or creaks. So here this is the it should not be creaked or kinked, and skin preparation fluid should not be allowed to sit under the plate. So if skin preparation fluid sit under the plate, it could burn and must be inspected at the end of the procedure. So that side should be inspected at the end of the procedure. Regarding patient, ensure all earth material object not in contact with the patient. And in laparoscopic procedure, ensure adequate fuel, carbon dioxide, pneumocranial, and well insulated instrument. Regarding diathermy, check the alarm wiring before use. Monopolar diathermy should be used in case should not be used in penis, fingers, testes, and solving. So in this 4 area, we should be very meticulous so that we don't use the monopolar diathermy, because these are the end artery. So the patient with a pacemaker try to avoid diathermy, but if it is not possible, then use bipolar diathermy. If monopolar has to be used, then patient should be far away from the pacemaker. So we have to follow the number 3 rules, that if it is has to be used, then it should be away from the pacemaker. But if the pacemaker happens, uh, it can create nuisance in the signal sending. So in case of these, so now come to the precaution of the safe use. What safety measure you will. So the question was safety measures using sugar. So yes, was the answer. What are the stapling device? And this is another Sodic production. So the stapling device, mechanical stapling device. Surgical staplers have changed the practice of the surgery in a profound way, most notably within the field of minimal invasive technology. Several different devices are available for stapling: skin stapler, ligating, and dividing stapler. At first, there is skin stapler, okay? Then this one, ligating and dividing stapler. Then GIA and gastrointestinal stapler. Okay, we will read later on. Surgical brainage. surgical drainage and surgical drain. This is another important question which we can read from Nexus, I think. Okay, so surgical drain. Uh, yeah, procedure for the drain. So again, we go to Nexus on the same area where there is drain. So here, this is the question that management of a drain, handling with aseptic technique, monitoring of the volume, color, consistency, and type of collection, monitoring of the frequency. 2 hourly during the operation day, we have to monitor 2 hourly during the operation day, 4 hourly during the subsequent day. Okay, and check for what we should check for. We should check for the drain site as secure by suture or tape. There is any redness, sign of leakage should be dry and clean. Drain tube. At first we have to see the site, the area where it is inserted. This is the site for the skin. The drain tube patency functioning, kinking or blocking. Laceted below and drain back. Support to give should be emptied daily. Now come to the documentation. Document the details daily and maintain flushing needed by biliary and pancreatic surgery. During transfer, special care during transfer of the patient. Open drainage system. To be assessed regularly, change dressing if it gets wet, and lost fluid to be replaced regularly. So surgical drainage classification and its uses. If we consider the classification, surgical drainage, there are external drainage and internal drainage. From the external drainage, if we drainage of the abscess, drainage of the body cavity, allostomy, colostomy, actually it's drainage, not drain. Gastrojejunostomy, colorectal pancreatic jejunostomy, jejunostomy vision, indication of the surgical drainage. Actually, it is drainage, but it is not drain. This is the short note of the. Okay, then drains are the device that is inserted to allow fluid or air that might collect in an operation site or in a wound drain freely to the surface. Removal of the foreign harmful material, acidic fluid, serum, bile, and chyle, etc. When there is a risk of leakage, operation of the dead space to decompress the allow air to decompress the and allow air to escape. diagnosis for postoperative hemorrhage. Early diagnosis of postoperative anastomotic leakage. Therapeutic value for fibrous tract removal. Therapeutic value of fibrous tract after removal. Type of drain. There are various type of drain. There are open drain, semi-open drain, and closed drain. Semi-open open drain, gravity, corrugated drain, and closed pack. These are the open drain, semi-open drain, capillary effective tube drain, and closed drain, suction drain, chest drain, underwater cell composition, silicone rubber, PVX, etc. Note the volume drainage 2 hourly operation. Documented color, consistency, type of drain. Maintain a clean, dry drain side. Support drain back. Ensure the tube isn't kinked and blocked. Biliary magnetic drain may require daily flush during translocation. Care should be given. Removal of the drain. Drain should be removed as soon as its purpose is served. Drain fluid is serous. Less than 25 ml per day. It could be removed. Okay, drain put in the cover on the following condition can be removed. Perioperative bleeding after 24 hours of the 20th tonsillectomy. Serous correction after 5 days of mastectomy because of infection. Immunization should be if there is in case of colorectal anastomosis removed after 5 days. The common bile duct remove after 10 days according to the situation. Any suction drain. Okay. Now again goes to the MCPS volume. Now this is another MCPS production. Minimal access surgery. The minimal access surgery, the limitation of the minimal access surgery scope and limitation of the minimal surgery history. Another production of the minimal access surgery. So we have to go to the minimal access surgery. 152. Okay, question. question is here. In the MCPS, it comes the limitations of the manual exercise. So here, core principles what is scope? So at first, so advantage and limitations. So here there is a first question: the advantage of the minimal access surgery as well as the limitations of the minimal access surgery. So here in my MCPS it is on limitations. So at first, the minimal limitations of the minimal access surgery, the reliance of the remote vision and operating. We have to see from the far away from the places, and loss of tactile feedback, dependence on hand-eye coordination, difficulty with hemostasis, and reliance on the new technique, extraction of the large specimen. So these all are important. First, there is a remote vision and operating. We have to operate by the remote vision and loss of tactile feedback. The dependence on the hand-eye, remote vision and operating, a lack of tactile feed, loss of tactile feedback, dependence on the tactile feedback, dependence on the hand-eye coordination, difficulty during hemostasis. So it is very difficult to hemostasis, difficulty during hemostasis. So there is bleeding, so it is the ligation, so it is difficult by the laparoscopy, and reliance on new technique and extraction of the large specimen. And this is a port, and this is a large gallbladder. Here is it. So from this port, large extraction large specimen is very difficult. So these are the limitations. No, it is very important for the first track surgery. So the first track surgery is multimodal evidence-based comprehensive program aimed to enhancing post-operative recovery and outcome by attenuating stress-related organ dysfunction. So, synonym multimodal rehabilitation enhanced recovery after surgery. Aim of fast track surgery or HIRAS protocol is to reduce physiological and psychological stress associated with the surgery, to minimize the pain and discomfort, reduce potential post-operative complication, reduce duration of hospital stay, enhance convalescence method, preoperative patient optimization area, improve anesthesia analgesia, minimal invasive surgery, perioperative fluid management, emphasize early oral feeding and nutrition, aggressive early mobilization. So it is very small but very effective. So again, if we ERAS protocol or enhanced recovery after surgery is the evidence-based comprehensive program, multimodal evidence-based comprehensive program to aim to enhance post-operative recovery and outcome by attenuating stress-related organ dysfunction. Synonym: multimodal rehabilitation, enhanced recovery after surgery, aim of faster surgery. Every surgery has some aim, so faster surgery can boost. Method: preoperative machine education, optimization, improvement of the anesthesia, analgesia, minimal invasive surgery, perioperative fluid management, emphasis on early oral feeding, aggressive early mobilization. This 4 point is extremely important. At first, MIS. Second, fluid management. Third, early oral feeding and nutrition, and aggressive early mobilization. Preoperative patient education and optimization, improve anesthesia and analgesia. So this is starts from the patient preparation. Okay. Now, okay. So